Good day, ladies and gentlemen. Thank you, organizers of Aegis 2020, for inviting me to give this lecture on principles and practice of diagnostic and operative hysteroscopy. This is the outline I'm going to go through today. We're going to talk about the indications, contraindications of hysteroscopy, instrumentation, preoperative preparation, anesthesia, distension media, training requirements, types of procedures you can do, of course, risk and complications. Hysteroscopy has indications: infertility, diagnosis and treatments, abnormal uterine bleeding, fibroid or polyp, uterine septal defects, Asherman syndromes, embedded IUCD, foreign bodies, and also for sterilization. And of course, you can use it for diagnosis and biopsies in case of endometrial malignancies. What are contraindications for hysteroscopy? This includes pregnancy, cervicitis, active pelvic infection, known cervical or endometrial cancer, and of course, a very important surgeon inexperience. How do we evaluate the uterine cavity? There are a number of modalities we can use, including 2, 3D or 4D ultrasound scan, HSG, virtual hysteroscopy, the new kid on the block that refused to take off. Hysteroscopy, of course, is the gold standard and is used for diagnosis and treatments. Benefits in recurrent implantation failure, recurrent pregnancy losses, and other endometrial pathologies are not in doubt. We also have MRI or CT scan that can give us a precise evaluation of the endometrial cavity. What are the equipments we need? We need hysteroscopes, of course, and other adjuncts. There are different types of hysteroscope: flexible hysteroscope or rigid. Miniature hysteroscope available nowadays to enable us to do vaginoscopy without without cervical dilatation. And of course, we have hysteroscopes in various degrees: 0 degrees, 12 degrees, 25 degrees, or 30 degrees hysteroscopes available. I am confident with 0 degrees. Allows me to have head-on view, and of course, some of my colleagues use 30 degrees to various indications, and of course they do have significant benefit from this as well. The choice of hysteroscope you use is left to the operator, and of course what you have in your department or unit. Modulators, lasers are oncoming and they are here now, and of course robotic, we are still experimenting with it. Compared to the time when Pantaleone was doing his own hysteroscope, we have now modernized hysteroscopies from the monitor, the telescope, the ANS instruments, the energy source, and of course the fluid management system. Everything is very modernized now, and to the benefit of the an advantage of the patients and of course the surgeon. Robotic modulator. Robotic hysteroscopy is about taking off, and we are still awaiting further evaluation of the process itself and the procedures, see whether it can be the gold standard for hysteroscopy now in the near future. What are the best pre-IVF hysteroscopy you can use? For mammectomy, you can pick one. You have laser, monopolar, bipolar, modulation, mechanical, electrical, robotic. And of course, you can use DNRH analog plus or minus energy or mechanical modulation plus laser to do your procedures. The type of equipment you have, as I said earlier on, depends on what you have in your department and of course your experience with any of this. Preoperatively, you need to take thorough history and physical examination of your patient. It's important. You need to treat comorbidities, blood pressure, diabetes. And of course, you are not going to do hysteroscopy when there is active gyne infections or when you have pregnancy. Obtaining informed consent is important, and you must give your patients information leaflets so that she can read when at her leisure, and to understand the risk available: bleeding, cervical tear, fluid overload, bowel injuries, and of course unscheduled laparoscopy or laparotomy. Most times we use tender loving care, especially if you're in the office, or conscious sedation when you are doing office hysteroscopy. We generally avoid general anesthesia these days, and of course we can use spinal or epidural, depending on whether you are doing this in the office or you are doing it in the theater. Distension media, mostly what we have are colloids, crystalloids, non-ionic liquids, and of course these are their pros and cons, and of course we also know that you cannot use crystalloids when you are using monopolar dissection, because it will not give you effective cutting or coagulation effect when you use crystalloids. You can use 5% dextrose, which is what we use in our center, and it's been working fantastic. The only risk here is you must avoid hyponatremia, and you improve your visibility if you use Endomat, Hysteromat from Carl Stores or any of the other manufacturers. You regulate the flow rates. You can also regulate and keep constant your intrauterine pressure. The fluid distension media also give you a better visualization as well, and you can carefully examine the cavity and do your treatments. The most important point about the distension media you are using is how to prevent fluid overload. And as we said earlier on, using appropriate distension media is important, and of course you need to use it with a good fluid management system like the Endomat from stores or Hysteromat from stores that's got rotary pumps that keeps the pressure and the flow rate constant for you, giving you good visualization. You have to keep your operating times to a minimum. This is important to avoid fluid overload. You have to avoid going into big vessels, especially if you are near the cervix, to avoid cutting into major uterine artery branches. Nice to keep your your intrauterine pressure at 80 to 100 millimeters of mercury. Monitor your fluid balance meticulously to avoid overload, and you have to stop if you are running above 1 liter or you have raised TVP. Avoid hyponatremia, and you have it. You have to be able to give some basic treatments or seek for help if you need it. And in case of ammonia toxicity, you can use hemodialysis. These are not the stuff you do on your own. You need help from other specialists. Hysteroscopy is not what you do without training, and there are different levels of training. Level 1, 2, 3. Level 3 are the masters that can do all the difficult cases: uterine septum, resection, endometrial ablation or resection, submucous fibroid more than 2.5 centimeters, division of major uterine synechia in Asherman syndromes, and of course, when you have severe cases, complex cases that need experience. There are, from the European Academy, we have European Diploma Program here, and you can visit their website. If you are interested, you can organize, you can get registered for this, and it's quite easy and not so difficult to obtain these certificates. You just have to provide proofs of your competence. We also do some training here, but this we need to consolidate better with AGs on board now. Hopefully, this can take off in the likes of Gesia in future. We can do hysteroscopy mainly in the office now, and is gradually coming out of the theater. And office hysteroscopy has very good benefit to the patients, and of course to your center and to the surgeon himself. You can consult with the patients, and you can see and treat at the same time. Doing office hysteroscopy is made possible now because we have miniaturized equipment now, and of course the advantages of cutting costs, no anesthesia, vaginoscopy mainly. You don't need to do cervical dilatation in most cases. You can do diagnosis, you can operate at the same time, and the recovery rate is very good, and the patients go home with little or no complications. Of course, when you have theater indications like obese patients, patients with comorbidities or fear of surgery, of course the patient decides not to do it in the office. You need to oblige the patient as well. This is diagnostic hysteroscopy, and mainly what you are trying to do is to find out, examine the endometrial cavity if there are pathologies, have a good panoramic view of your cavity, check that you can see the two ostia simultaneously, look on the anterior wall, posterior wall, all the two lateral walls, the two ostia, rule out fibroids, and then when you are coming out, gradually withdraw your hysteroscope, examine the internal walls, examine the cervical canal, and also the cervix itself and the vaginal wall. Finally, have a good view, check there is no fibroids, and then you can be confident there is no pathology here. When we talk about submucous fibroids, you need to have a good classification system that you use in your center to be able to decide what the type of fibroid, submucous fibroid you have, what's your competencies in terms of doing it in the office or in the theater. You can use ESGE, Wamsika classification system, type 0. The fibroid is completely in the endometrial cavity. Type 1, more than 50% of the fibroid is in the cavity. Type 2, when you have less than 50% of the submucous fibroid in the endometrial cavity. I prefer to use the LASMA pre-surgical classification because it takes cognizance of the size of the fibroid, the topography, the extension of the base of the fibroid, the penetration of the myometrium, and you can use this to calculate a score. And based on this, you can determine the easiness of doing the removing the fibroids either in the theater or in the office, or if the fibroids is not amenable to treatment by hysteroscope, you can use this score easily. These are available on the internet, so I won't go into too much detail here. The techniques of doing successful, effective hysteroscopic mammectomy, of course, we have the mechanical way of doing things, including the cold loop. We have resection using your resectoscope. We have Vasa points, Malshore through clear mechanical modulators, and of course we have lasers, and as I mentioned earlier, robotic mammectomy is also coming on board very soon. This is operative mammectomy, and this is a video just to highlight the various techniques you can use. As we can see the fibroids here, and as I mentioned earlier, you can use slicing techniques. You can use cold loop to bring out the fibroids. Eventually, you can use section to do it. And now, as I mentioned, you need to understand the size and characteristics of the submucous fibroid you have, the base, and the extension of the fibroids into the endometrial cavity will determine what kind of instruments you are going to use, whether you are doing it in the office or in the theater. And the size of the fibroid also determine the surgery time, which is important. You must be careful when you are going beyond 1 hour. Then you need to be careful about fluid overload. Asherman syndrome is very common in our environment because of septic abortion and, of course, inappropriately done uterine surgeries that involve the endometrial cavity. And it can cause scanty, irregular menstruation or complete amenorrhea. Pelvic pain is also important. Incidence is about 25 to 30%, maybe higher in our environment, and the consequences include infertility, recurrent miscarriages, placenta pathologies, APH, PPH, and as we see now on the slide, we can diagnose this using ultrasound scan, sonohysterography, or HSG. These have almost similar sensitivity and specificity, and hysteroscopy is the gold standard for diagnosis and, of course, for treatments. This is videos of adhesions, which you can either use with modulator, through clear modulator. You can use that to do the adhesiolysis, or you can use the good old hysteroscopy scissors to do your adhesiolysis. When you do your adhesiolysis, this is a cavity uterus. The right side of the cavity is completely occluded by adhesions, and we can see the ostia on the left, but on the right side we cannot see anything. And using hysteroscopic scissors, we could use this to dissect out the adhesions. You continue, you can see the adhesion fibers, you continue until you can get to the muscle layer, when you start seeing blood vessels, and then you know this is the time for you to stop. You have to be careful here because two things: you don't want to perforate the uterus, and at the same time you want to minimize the time you use when you are doing this adhesiolysis, because sometimes there may be significant risk of fluid overload, especially if you go beyond 30 minutes, 45 minutes, or up to 1 hour. This is a second look hysteroscopy for adhesiolysis. The first look was done because this patient has a complete endometrial occlusions, and we did the first stage, and then we come back to the second stage to finish the process, and we created a good cavity space for the patients, and the patient can either have spontaneous pregnancy or can proceed to IVF. So you can see the cavity now is well outlined. Post-operative additions therapy, there are many: hyaluronic acid, polysaccharides, cellulose, combination of the above, hormone therapies, and of course balloon catheter, IUCD, and amnion. And of course, we know now that Cochrane systematic review has shown that all these processes have uncertain clinical effectiveness, but anecdotal evidence suggests that we do get some benefit from this, and we can see this from a comparison of 2 adjunctive treatments for intrauterine additions following lysis by Professor Ray and team, and they found out that using Foley catheter compared to copper TLUZD restore menstruation better, prevents second look additionalysis, and improves conception rate. What we are seeing nowadays are post-mammectomy residual nylon stitches. This is becoming very uncommon. I don't know whether we are regressing in our techniques, while we still find some of our colleagues using nylon for mammectomy. And we can see this can become very difficult to remove, especially when you have extension outside the stitch is extended outside the uterus itself. You can only remove what you see, but what is in the mammalian that you don't see, you may not be able to remove. And this may be necessary to do, may make it necessary for you to do laparotomy or laparoscopy for removal. Please, this is to be discouraged when you are going to use absorbable sutures to do mammectomy. Now, talking about infection, this we know that is not very uncommon, and it could cause delayed maturation of endometrium, so causing abnormal implantation, recurrent pregnancy losses, pelvic pain, and it may be due to chlamydia, GBS, E. coli, herpes, or tuberculosis. Diagnosis depends on ultrasound scan, HSN, where we see micropolyps, and hysteroscopy as well. And treatment usually after you've done IV vaginal spore for microscopic culture and sensitivity, you can give broad spectrum antibiotics, and in TB endometritis, antituberculous medication, and these are very effective therapy for this pathology. Now, hysteroscopy also you can use to retrieve lost IUCD that's still in the cavity, only that the thread has migrated into the cavity. You can use simple vaginoscopy and hysteroscopic grasper to pull on the thread and pull the IUCD out of the uterine cavity. Doing septal surgery, we know that there's controversy over this, but what is not in doubt is that if you have extensive septum, removing this is beneficial to infertility and prevents recurring pregnancy loss in some cases. And we can see that 80% of this septum are vascular. So when you are doing this surgery, you need to be careful if you are using scissors or any mechanical process, that if you encounter bleeding, then you must get your energy ready to stop the bleeding. It is important to rule out biconate uterus in these cases, and you have to depend on preoperative diagnosis using 3D ultrasound scan, or in some cases MRI or laparoscopy as well. We did a retrospective analysis in my center from 2013 to 2018, where we found we did about 304 hysteroscopies, and we found out in terms of what is there in the pathology that we saw. We found out that submucous fibroid is much more, up to more than 80% of, more than 80% more than 27%, more than a quarter of it, of the what we've done are fibroids, followed by adicholysis. And of course, we also have IUCD removal, combined mammectomy and polypectomy as well, not insignificantly. In terms of complications, you can classify into immediate and delayed. Immediate, you can see quickly and you can offer treatment. If it's bleeding or you detect perforation, you need to rule out whether there is bowel injuries, and if you are going to do laparoscopy or laparotomy, depending on your experience, to solve the problem, you should be able to do that. And you have to avoid fluid overload, and you need to make a good choice about the kind of media you use and avoid too much hair bubbles in the cavity to prevent embolisms. Complications are more rampant if you do operative compared to diagnostic, and complications also could be delayed in some instances, especially infections, Asherman syndromes, adenomyosis, cervical scarring or occlusion, hematometra, infertility, and pregnancy complications. Percentage of complications varies from center to center, about 1% to 3%, and in most cases is not up to this. It's below 1%. In our center, we have about 1.2%, so comparable to what obtains out there. Complications occur in cases when you have difficult cervical dilatations, and solutions to this are here. You can prevent this by proper positioning your patients, avoiding to do improper dilatation or forceful dilatation. You have to be gentle, proper placement of the vosculum. If you want to use laminaria, in some instances, some people prefer to use misoprostol when they put it in either 2 hours prior to surgery or some 24 hours before surgery. And of course, there are some instances where you can do dilatation under ultrasound guidance. You have difficulty in dilatation, especially if you have stenotic cervix, nulliparous patients, menopausal atrophic cervix, and cervical scarring from previous surgeries, or when you have severe retroversion or anteversion of the uterus. One of the complications that is common is hemorrhage, and this can be due to tenaculum injury, cervical tears, or perforations. And when you have deep cervical laceration, as we mentioned earlier, can cause severe bleeding, absorption of fluid, and causing fluid overload, hypovolemic shock, rarely death. So this needs to be avoided. And what do you see? Your vision is completely occluded, and you are forced to try and do something to stop the bleeding before you can proceed, because you may not be able to see anything at all. And if you want to proceed, you either cauterize the vessel or you stop the procedure altogether to look after the patients. How do we manage persistent bleeding? Usually you stop the procedure if it's severe. You can do coagulation of the endometrial bleeding points. You can insert a Foley catheter after the procedure, or uterine balloon catheter for tamponade. You can use oxytocin or misoprostol. Of course, after the procedure, you need to give broad-spectrum antibiotics. And in extreme cases where you feel that you may have perforated uterus, you can resort to laparoscopy or laparotomy for definitive treatment. You need to give the patient good follow-up and post-operative monitoring. This is a slide of uterine perforation done inadvertently, of course, in our center. And as you can see, you may not be able to know this if you are not very conversant with what you see during the procedure. What you see is you can see bleeding, hemorrhage, you can see loss of pressure, and you won't be able to see anything. You must be suspicious when you see that your endometrial cavity suddenly collapsed and you cannot see anything but blood. And then in this case, you need to be careful, proceed gently, and if you are not, you see momentum in front of you, and then you know you are perforated. Then in these kind of cases, it's good to do laparoscopy or laparotomy to assess and to see the potential of what injuries are there and what you can do for repair, especially if you have bowel injuries. Sometimes you may need to involve GIT surgeons. How do you prevent perforation? Experience is very important. You leave difficult cases to experienced hysteroscopists, like severe Sherman syndrome, type 2 or 3 submucous fibroids. And of course, you have to be very cautious if you are doing electrosurgery. Only cauterize when you are in good view of what you are doing. Only resect if you are in good view of what you are doing. And then sometimes you may need to combine it with ultrasound scan or laparoscopy for effectiveness of your procedure. In summary, using appropriate hysteroscopic and operative techniques has a number of benefits, including fertility and menstrual regularity. And complications may occur whether you do diagnostic or operative hysteroscopy. The complication rate in diagnostic hysteroscopy is lower compared to when you do operative hysteroscopy. And operative hysteroscopy is very much common to sustain injuries than diagnostic, and this can cause significant morbidity and mortality. Thank you. I'm available to take questions.